Готово.
Так, а где я буду видеть этих
Присутствующие?
присутствующих?
Они вот с края здесь в чате должны писать.
Вот здесь они
Да.
появятся, да?
Ну, есть еще возможность увидеть количество людей, которые подключаются. Вот. Но это надо сворачивать, немножко неудобно.
Неудобно. Ну, тогда ждем и
да.
поехали. Спасибо. Well, good afternoon, everybody. So today we'll start our lecture. Acute renal failure. You see now the topic we'll discuss today. So we'll start from definitions. Acute renal failure. So it's the loss of renal function over hours to days, and we measure this loss of the renal function as glomerular filtration rate fall, and it is expressed clinically as retention of nitrogenous waste products in the blood. Few words about definitions we'll use today. Azotemia, it's the accumulation of nitrogenous wastes. Uremia, symptomatic renal failure. Oliguria, when the urine output is below 500 milliliters per 24 hours. and anuria when the urine output is below 100 milliliters per 24 hours. What are the manifestations of an acute renal failure? Azotemia, which progresses to uremia, appearance of hyperkalemia, the development of the metabolic acidosis, the presence of volume overload, hyperphosphatemia, and the accumulation and toxicity of medications excreted by the kidney. Classification of the etiologies of acute renal failure. We distinguish such variants of an acute renal failure like prerenal acute renal failure, intrinsic acute renal failure, and postrenal acute renal failure. And the intrinsic acute renal failure divides in few types. Now you see 5 types. The first is acute tubular necrosis, the next acute interstitial nephritis, then acute glomerulonephritis, acute vascular syndromes, and at last intratubular obstruction. Now we'll discuss prerenal acute renal failure. It is accompanied by volume depletion, but better to say caused by a volume depletion, with the decreased effective blood volume. In such conditions like congestive heart failure, liver cirrhosis, nephrotic syndrome, sepsis, and partially with renal vasoconstriction due to hepatorenal syndrome, hypercalcemia, and non-steroidal anti-inflammatory drugs. How to treat? We have to correct volume deficits. We have to stop some antagonizing medications like NSAIDs and cyclooxygenase 2 inhibitors, to stop diuretics, not to stop but consider the avoidance of diuretics, and optimization of cardiac function whenever if we see the heart failure. Intrinsic acute renal failure, I simply here repeat, we consider acute tubular necrosis, acute interstitial nephritis, acute glomerulonephritis, acute vascular syndromes, and intratubular obstruction. Acute tubular necrosis. It may be ischemic due to prolonged prerenal azotemia, due to hypotension, due to hypovolemic shock, due to cardiopulmonary arrest, and in some cases following the cardiovascular surgery in cardiopulmonary bypass. But the most significant is the septic condition. And also we consider some nephrotoxic effects, usually drug-induced, with radiocontrast agents, aminoglycosides, antibacterial drugs, amphotericin B, cisplatinum, acetaminophen, and sometimes pigment nephropathy due to hemoglobin overload and myoglobin, usually in the crash syndrome or active chemotherapy in some malignancy. How to treat acute tubular necrosis? We have to use supportive therapy, Remember, no specific pharmacological treatment exists here. And we must keep in your mind acute dialysis for such conditions like volume overload, metabolic acidosis, hyperkalemia, uremic syndrome, and uremic syndrome accompanied with pericarditis, encephalopathy. It's, by the way, the terminal conditions, and at last azotemia. What is the prognosis of an acute tubular necrosis? It's the rather hazardous condition because the overall mortality varies around 50%, and recovery of renal function seen in about 90% of patients who survive, who are lucky with this condition, but although not necessarily back to prior baseline renal function. And at last, mortality strictly depends on comorbid conditions which finally led to development of the acute tubular necrosis. The next, acute interstitial nephritis. We consider here the situation due to lymphocytic infiltration of the interstitium with the classic triad of fever, rash, eosinophilia. Acute interstitial nephritis may be drug-induced due to the series of antibacterial drugs like penicillins, cephalosporins, sulfonamides, rifampicin, some anti-seizure drug like phenytoin, furosemide surprisingly, and at last NSAIDs. It may be induced by malignancy. It may be associated with any type of infection like bacterial, viral, rickettsial, tuberculosis, associated with systemic disease like systemic lupus erythematosus, sarcoidosis, Sjogren's syndrome, tubular interstitial nephritis, and uveitis. And at last, it may be idiopathic without any clear etiology. How to treat an acute interstitial nephritis? We have to stop offending drug. You have to treat underlying infection, treat systemic illness if it really present, and glucocorticoid therapy may be used in patients who fail to respond to more conservative therapy. Acute glomerulonephritis. Nephritic presentation with the proteinuria, but this proteinuria may achieve the nephrotic range exceeding 3 grams per day. Then hematuria, appearance of red blood cells casts, and this diagnosis usually requires renal biopsy. Fortunately, it happens rather infrequently. The next, acute vascular syndromes like renal artery thromboembolism, renal artery dissection, renal vein thrombosis, and atherembolic disease. Fortunately, not so widespread conditions, we meet them rather rare. And at last, intratubular obstruction. It depends on intratubular crystal deposition associated with so-called tumor-lysis syndrome. Usually it looks like an acute urate nephropathy due to the massive destructions of the cells. Then some poisoning with ethylene glycol toxicity with calcium oxalate deposition. The next point, intratubular protein deposition associated with pathological protein overload, overcharge with multiple myeloma, and it is association with the production of Burns-Jones protein with further deposition in tubular system. Well, the next, post-renal acute renal failure. It usually looks like urological problem, urinary tract obstruction. We distinguish the level of obstruction. It may involve upper tract ureters and lower tract bladder outlet or urethra. And we also have to evaluate the degree of obstruction. It may be partial and complete. And you see here post-renal acute renal failure with the levels of the obstruction. Here you see the point, it's the proximal part of ureter. Here are the ureters. And it may be usually associated with some congenital inherited problem, maybe acquired hydronephrosis, how it looks on ultrasound examination. How to treat post-renal acute renal failure? I want to repeat, it's the urological problem. We have to relieve the obstruction with bladder catheter. In the case of lower tract obstruction and upper tract obstruction with the usage of ureteral stents, percutaneous nephrostomies. And the recovery of renal function depends on duration of obstruction. We must take into account the probable post-obstructive diuresis, so we must to see it. Differential diagnosis of an acute renal failure. We simply repeat this slide. We distinguish prerenal, postrenal, intrinsic acute renal failure. How to evaluate if we suspect the presence of the acute renal failure? We have to evaluate for prerenal causes with the usage of the regular clinical examination with blood pressure measurement, the evaluation of orthostatic reactions to measure central venous pressures and cardiac output, intake output record, evaluation, investigation of urine sediment, urine sodium, if the urine sodium is below 20 millimole per liter, and therapeutic trial of volume replacement. It plays the role for prerenal causes. For intrinsic acute renal failure, the same, we have to analyze the clinical history, the usage of medications, the situations associated with low blood pressure, physical examination, sure, and urinalysis for investigations of the crystals and paraproteins. How to evaluate for post-renal causes? We have to perform bladder catheterization, and sure, renal ultrasound, it's the most valuable investigation for such situations. Management. For prerenal acute renal failure, we have to provide volume repletion, inotropic support, and discontinue diuretics. For postrenal acute renal failure, to perform bladder catheterization, percutaneous nephrostomy or urethral stents, and fluid management during post-abruptive syndrome. For intrinsic acute renal failure, we have to provide general supportive care like fluid management, diuretics, bicarbonate supplementation, potassium, phosphate, drug dosing, and nutrition. The indications for dialysis, sometimes we have to consider such treatment. We consider the acute hemodialysis in the presence of volume overload, metabolic acidosis, hyperkalemia, uremic syndrome, especially in the presence of uremic pericarditis and encephalopathy, and at last, azotemia. Now we move to chronic renal failure. I want to remind the general functions of the renal system before we start to discuss chronic renal failure. The functions of the renal system include elimination of metabolic wastes, regulation of red blood cells production, regulation of vitamin D and calcium metabolism, regulation of blood pressure, and regulation of electrolyte, acid base, and fluid balances. You see here that the functional unit of the kidney or the heart of the kidney is nephron. And every kidney contains about 1 million nephrons. And each nephron can perform all individual function of the kidney. A few words about definition. Chronic renal failure, it is a progressive and irreversible loss of renal function over a period of months to years. And the kidneys can lose up to 80% of all nephrons with relatively few other changes in function of the body. And nephrons are destroyed and replaced with scar tissue with remaining nephrons become hypertrophied and eventually fail to function. And it results in alteration in all of body's system. What are the most common causes of chronic renal failure? I'd like to say any kidney disease, which include glomerulonephritis, interstitial nephritis, diabetic nephropathy, hypertensive nephrosclerosis, polycystic kidney disease. You can compare the gross morphology of renal scarring. On the left side, you see the normal kidney. On the right side, the scarred kidney, probably already lost the functioning nephrons. It's the end-stage kidney disease. I'd like to say end-stage chronic renal failure. We can discuss many classifications of the chronic renal failure, but in general, chronic renal failure usually occurs at the glomerular filtration rate below 25 milliliters per minute. We can here consider 4 stages of decreased renal function. Silent, when GFR is up to 50 milliliters per minute. Renal insufficiency, when the glomerular filtration rate is in the range of 25 to 50 milliliters per minute. Obvious renal failure, when GFR is from 5 to 25 milliliters per minute, and at last end-stage renal failure with glomerular filtration rate below 5 milliliters per minute. Azotemia or uremia, azotemia, these are the synonyms, is a term applied to the manifestations of organ dysfunction seen in stages 3 and 4 of chronic renal failure. Literally, uremia means urine in the blood, but sure, it's impossible, but this terminology was born more than 200 years ago. Azotemia means the accumulation of nitrogenous waste products, chiefly predominantly urea in the blood, and it is the hallmark of renal failure. And it is a clinical syndrome resulting from retention of certain substances which are normally excreted into the urine and thus accumulate, causing toxicity. What are the general chronic renal failure symptoms? Subjective, like metallic taste in mouth, weakness, irritability, fatigue, nausea, anorexia, pruritus. And objective, ammonia or urine odor to breath, oliguria and anuria, tachycardia, arrhythmias, hypertension, rapid weight gain, dry scaly skin, and at last peripheral edema. Clinical manifestations. Retention of nitrogenous wastes lead to increased blood urea nitrogen, and serum creatinine, and uremia with the signs and symptoms of azotemia. And you can see the fluid volume excess. The next, metabolic imbalances with electrolyte imbalances, which are hyperkalemia, hyperphosphatemia, hypocalcemia, hypermagnesemia, and delusional hyponatremia. The next, acid-base imbalances with metabolic acidosis with low pH and low bicarbonate. Effects of renal failure on the body systems: genitourinary with oliguria, with the changes in urinalysis, with the appearance of casts, erythrocytes, leukocytes, and protein, the decreased specific gravity and fixed at the level at 1010 and below than 1010. And urine osmolarity is less than serum osmolarity. And creatinine clearance is decreased. Neurological symptomatics look like fatigue, confusion, lethargy, changes in level of consciousness, and at last, in the end-stage disease, with the development of seizures and coma. The next, cardiovascular problem, may accompanied by arrhythmias, hypertension, hyperlipidemia, and peripheral edema, with heart failure and development of uremic pericarditis. If we discover the uremic pericarditis, we name this situation like funeral bells. It's the end stage situation. The next, respiratory, Kussmaul respirations, crackles and pulmonary edema, and at last uremic pleuritis. Gastrointestinal problem, anorexia, stomatitis, metallic tests in mouth, and uremic fetor. And at last, gastrointestinal bleeding, the most serious problem. The next, integumentary, like pruritus, dry skin, brittle nails and hair, echymosis, pallor or yellowish bronze discoloration of the skin. And in terminal stage of chronic renal failure, uremic frost rare today because such patients must be treated before the development of this uremic frost. Musculoskeletal, muscle cramps and weakness with foot drop. And long-term problem, the development of renal osteodystrophy resulting in bone pain, deformities, and pathological fractures. The next, hematological problem with anemia, decreased level of platelets, which leads to prolonged clotting times and decreased leukocytes. Endocrine problem, glucose intolerance, and at last, reproductive function, decreased libido, and infertility. Complications Better to say these are the clinical features. We now can also consider it like complications with seizures, coma, heart failure, pericardial and pulmonary effusions, gastrointestinal ulceration and bleeding, renal osteodystrophy, and at last secondary hyperparathyroidism. How to treat? Sure, the best treatment are the chronic hemodialysis or better kidney transplantation. But before it, we have to improve the functions of the kidney, partially improve, sure. We have to correct fluid imbalance with fluid restriction. Uh, we have uh, consider the level of fluid restriction like 24 urine output plus 500-600 milliliters of any kind of fluid. The essential is daily weights and input outputs. But better, the best way to analyze the fluid intake and output is the daily weights. Control the daily weights because the monitoring of input and output may lead to some mistakes. The weight is the best for such purposes. And treatment for hyponatremia. Then diuretics, loop diuretics like furosemide or etacrinic acid, osmotic diuresis with mannitol, and both such types of diuretics like loop diuretics and osmotic diuretics both promotes diuresis and increases renal blood flow. How to control hyperkalemia? The best way is hemodialysis, remember it please. But we can partially control hyperkalemia with the usage of intravenous glucose accompanied by regular insulin. It forces potassium move out of serum into cells. The next, intravenous sodium bicarbonate. It creates temporary alkalemia moving hydrogenase out of cells and allowing potassium to shift into cells. The next approach is the usage intravenous calcium gluconate. It reduces myocardial irritability and decreases the risk of arrhythmias. And the usage of polystyrene sulfonate, carboxylate. It's the cation exchanges resin which binds with potassium in bowel, promoting elimination in stool. Well, how to control hyperphosphatemia? We have to use phosphate binders. These binders bind to phosphate in bowel and promote excretion in stool. It should be given with meals. The particular names are renal gel or calcium acetate. How to control hypocalcemia? We have to add the supplements of calcium and synthetic active vitamin D, like calcitrol, locatrol, and so on. Acid-base imbalances. Metabolic acidosis we can control with intravenous sodium bicarbonate. To control elevated blood pressure, we can use angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, and calcium channel blockers. Anemia should be controlled with red blood cells transfusions, usage of epogen, it stimulates erythrocyte production, and ferrous sulfate, folic acid supplements. How to prevent the complications and to manage the symptoms? We can use anti-seizure drugs, anti-ulcer drugs, antiemetics, antibiotics in the presence of some infection with the ensuring of the renal dosing, and antipruritics. I already have told you about the best treatment. The best treatment is renal dialysis. Sure, transplantation is better. Two types of hemodialysis, the real hemodialysis and peritoneal dialysis. What are the indications for chronic dialysis? End-stage renal disease with hyperkalemia, nausea, vomiting, anorexia, mental confusion, increasing lethargy, fluid overload despite medical therapies, pericardial friction rub, which indicates an urgent need for dialysis. I told you, funeral bells, pericardial friction rub means. Hemodialysis. It is the most common method of dialysis. May be used for lifelong therapy, usually 3 times a week for 3 to 4 hours each session. It prevents death but does not cure renal disease. In general, dialysis machine removes so-called dirty blood, cleanses it, and then returns it to the body. We have to provide the vascular access. We must have dialysis machine and provide the dialysis. These are the tube-like apparatus containing a semi-permeable membrane and dialysate solution. This solution contains all important electrolytes in ideal cellular concentrations. And this dialysate solution can be adjusted based on the patient's need. Look please how looks this equipment, dialysis machine and dialyzer, hollow fiber dialyzer you can see here. It looks like tube with many hollow fibers, and these fibers border with the dialysate solution through this high-end technique semi-permeable membrane. And the process of hemodialysis looks like blood is removed from the arterial end and pumped through the dialysis machine to the dialyzer at the rate of 200-400 milliliters per minute. The heparin should be added to blood to prevent clotting in the dialysis machine. And the dialyzer receives arterial blood flow along one side on the semi-permeable membrane with the dialysis solution flowing along the other side, usually in the opposite countercurrent direction. And the physical processes are osmosis, diffusion, and ultrafiltration. and then the filtered blood is returned through venous access to the patient. The next, peritoneal dialysis. The main types of it are continuous ambulatory peritoneal dialysis and continuous cycling peritoneal dialysis. It may be completed in the home with the exchanges of dialysate solution performed 4 to 5 times a day, 7 days a week, dwell time from 4 to 8 hours. What are the advantages? More consistent, less electrolyte imbalances, frees patient physically and mentally from dialysis center. But what are the disadvantages? These are the susceptibility to infection because the patient must uh, complete exchanges at more frequent intervals. It means less freedom for work and social engagement outside the home. Why the infection? Because the patient must interchange the idealizate solution, which it inserts into the abdominal cavity through the special catheter. And this catheter must be prevented by any type of infection. How to override this problem, we really don't know. Nowadays, the best resolution of this trouble is kidney transplantation. The average cost of maintaining a successful kidney transplantation is 1/3 the cost of dialysis. But what is the main problem? It's the lack of donors and also some law restrictions in different regions of the world. As for our country, we also have many troubles when we try to find the appropriate donor. Two types of human donors exist: living donor, related or non-related, in our country, related donor, and cadaveric kidney, more available, but not so, it provides not so better outcome. So the living kidney is the best choice for such purposes. And now you see the lifeline for this patient. So dialysis, we can continue hemodialysis or continue peritoneal dialysis, but in any case, you have to consider kidney transplantation. Nowadays, kidney transplantation is a routine procedure, and it provides rather good quality of the life. So we must take into account the necessity of the usage of medications which prevent the rejection of this transplanted kidney. Now I want to say thank you for attention and wish you take care. Goodbye. Now you can ask some questions if the questions evolve. Well, now no questions, and we finish the translation. Thank you once more. Goodbye.